Good afternoon, everyone. We'd like to welcome you. My name's Monica Rossley. I'm from Prince of Wales Hospital in Sydney, and my co-moderator is David Patterson from Royal Brisbane Hospital in Brisbane, Queensland. That's good. Okay, it's my pleasure now to ask Meg Parisi, who's the head of nuclear medicine at Seattle Children's Hospital, to present her paper on current recommendations in paediatric thyroid cancer management. Thank you very much, Meg.
Thank you, and I'm delighted to be here. I have no disclosures, a few acknowledgements, my colleagues on numerous papers and committees. And hopefully by the time I'm finished, you should know that there are pediatric-specific management guidelines for children with thyroid cancer, have a familiarity with the diagnostic algorithm for evaluation of thyroid nodules in kids, and be able to list a few differences in the approach to the workup of thyroid nodules in children compared to adults, as well as several important differences between adults and children with differentiated thyroid cancer. 10% of all thyroid cancers occur in those less than 21 years of age, and it's important to remember that the biologic behavior of thyroid cancer is different in kids than adults. Typically, we're going to see the well-differentiated papillary follicular subtypes. All the other types are really quite rare. As we heard, children typically present with advanced disease at diagnosis. So there'll be extensive regional nodal involvement in 60 to 80% compared to 30 or 40% in adults. They have a higher rate of distant metastases, higher local and distant recurrent rates, higher rates of genetic mutations. But on the other hand, they have a rapid response to therapy and an excellent prognosis with a 10-year mortality of less than 10% and an overall survival of greater than 95% at 20 years and overall 98% versus a 40% 5-year and 20% 10-year survival in adults with distant or pulmonary metastases. But unfortunately, progressive occurs in a significant proportion of patients, and progressive-free survival is only about 70% at 5 years. Recognizing that children are not small adults, the American Thyroid Association put together a multidisciplinary task force which worked together to produce 61 graded recommendations in 34 key areas of evaluation and treatment based on available scientific evidence, and reported in the manuscript listed below, published in Thyroid in 2015. So let's talk a little about the clinical presentation in children. They can present with one or more asymptomatic neck masses, and if you look, the incidence of neck masses is much higher in adults, but the risk of malignancy in one of those masses is only 5%. Whereas in children, maybe there's a 1% chance of having a neck mass related to a thyroid nodule, but a third to 50% of those will have malignancy. Children can also present with diffusely infiltrative disease resulting in gland enlargement, which is often associated with microcalcifications. They can also present with just cervical lymphadenopathy. So evaluation is the same as in adults: history, physical, laboratory, but we use high-quality neck ultrasound in further evaluation, and then fine needle aspiration. Ultrasound's used to distinguish cystic from solid lesions, and as you know in adults, while cystic lesions are typically benign, up to 50% of malignant lesions have a cystic component, and 8% of cystic lesions can represent malignancies. We also use ultrasound to quantitate the size and number of nodules, assess for the presence of cervical lymphadenopathy, detect non-palpable lesions, and guide fine needle biopsies. And occasionally there is a use for CT or MR. So what are the distinguishing ultrasound characteristics? Malignant nodules, as you see here, maybe. There we go. Well, okay, I'll use the mouse. We'll demonstrate indistinct margins, as you see here, variable echo texture, increased intranodular blood flow, and microcalcifications on ultrasound, whereas benign solid lesions are more likely to be homogeneous, have a halo, and lack internal calcifications. Here's an example of a thyroid ultrasound in a 15-year-old who had a year history of weight loss, hoarseness, and difficulty swallowing. And there's a large solid nodule with microcalcifications in the right lobe of the gland and a normal left gland, and this patient had papillary thyroid carcinoma. Another example, an 11-year-old with multiple neck masses. There's multifocal masses within the right lobe of the thyroid gland, as well as cervical lymphadenopathy, and this patient had extensive metastatic disease. We know that both protegnatate and I-131 have been used in the diagnostic evaluation of thyroid nodules, and while both expose the patient to ionizing radiation, neither is particularly helpful in excluding thyroid cancer, as most nodules are cold or have similar uptake to normal thyroid tissue, and further, that only a small minority of cold nodules are cancer as opposed to something more benign. Now, here's an example of a high-risk patient, a 16-year-old who previously had bilateral retinoblastoma, globe enucleation, who came in and also had radiation therapy to the eye and neck for recurrent disease, and came in with an enlarging mass in the right lobe of the thyroid gland, which was cold. So this patient, needless to say, high risk for secondary malignancy, underwent total thyroidectomy, but fortunately only had a multinodular goiter, as opposed to this previously healthy 4-year-old with an enlarging neck mass, and we can see a cold nodule in the left lobe of the thyroid gland, also seen on CT, which was metastatic PTC. So in adults, this is one of the differences. Nuclear medicine imaging is used in those with nodules and suspected hyperthyroidism or excessive multinodular goiter. But in kids with nodules, I-123 should be obtained only in those who have a suspicious nodule and a suppressed TSH level. And if a hyperfunctioning nodule is identified, then these patients immediately go to lobectomy plus isthmusectomy, because 30% of children will harbor an incidental differentiated thyroid carcinoma associated with an autonomously functioning nodule, compared to about 3% in adults. Here's an example. This is a 15-year-old who presented with hyperthyroidism, cystic mass on ultrasound with multiple hyperemic solid nodules. The I-123 scan demonstrates uptake in the hyperfunctioning nodules with suppression of the rest of the gland. This patient underwent a hemithyroidectomy, but had a follicular adenoma. So remember that the management of autonomously functioning nodules is different in kids than adults. So in adults, patients can have either I-131 ablation or ethanol ablation or surgical resection. But in children, since 30% of autonomously functioning nodules can contain an incidental differentiated thyroid cancer, the new guidelines recommend that lobectomy be performed. Also, it's important to recall that although helpful, imaging cannot distinguish between benign and malignant lesions or between malignant histologies. So fine needle aspiration is extremely cost-effective and very accurate, and results are similar in terms of sensitivity and specificities when compared to adults. So therefore, FNA is preferred to excisional biopsy in children. Here's an example. This is an ultrasound in a 13-year-old male with a palpable neck abnormality, and we see a large, solid nodule within a diffusely heterogeneous gland. FNA suggested lymphoma, and following total thyroidectomy, this child did have diffuse large cell lymphoma associated with chronic Hashimoto's thyroiditis. So remember that for children, all FNAs performed should be ultrasound guided. So in the older ATA adult guidelines, FNA was not indicated for small lesions unless the patient was high risk or if there were pathologic lymph nodes present. On the other hand, in children, as is now recommended for adults, the ultrasound characteristics and clinical context rather than size alone is used to determine if nodules warrant FNA. Ultrasound should be used, as I said, to guide all FNAs performed in children. We don't have to do an FNA of a hyperfunctioning nodule as long as you're going to take the lesion out. And that surgery, including lobectomy with isthmusectomy, is recommended rather than repeat FNA for all nodules with indeterminate cytology. And here's an example. This 17-year-old with Graves' disease came in to get an estimation of gland size prior to I-131 ablation, and what we found was a solid heterogeneous nodule with calcifications in the left lobe. Ultrasound-guided FNA was indeterminate, and remember, surgery is favored for all children with nodules and indeterminate cytology, given that there's an increased probability of malignancy as compared to adults, and this patient did have papillary thyroid carcinoma with metastatic involvement. So this is the diagnostic algorithm suggested in the pediatric specific guidelines. So if you have a solitary or suspicious thyroid nodule, which is detected, if the TSH is suppressed, the patient gets I-123 scan and uptake. If it's hyperfunctioning, it's removed. If the nodule is not hypofunctioning, if it's hypofunctioning, or if the TSH is not suppressed, the patients go on to get FNA under ultrasound guidance, and then there are pathways for whether the pathology comes out to be benign, inadequate, or non-diagnostic, indeterminate, or suspicious and malignant. So I refer you to that article for further evaluation. So what do we do preoperatively in the patient who's diagnosed with thyroid cancer? We do a comprehensive neck ultrasound. We consider contrast-enhanced CT or MR in those with large fixed masses or vocal cord paralysis, remembering that the use of iodinated contrast will delay post-operative evaluation and treatment with radioactive iodine if needed. Chest X-ray or non-contrast chest CT is used only in those with differentiated thyroid cancer and extensive cervical lymphadenopathy, as the prevalence of lung metastases is increased in this group. Limited role for I-123 in those who have suppressed TSH, and of course, FDG PET-CT is not recommended in routine evaluation. So what about treatment? So while death from differentiated thyroid cancer is low, recent studies have shown an increase in all-cause mortality for survivors of those with differentiated thyroid cancer, predominantly due to the development of secondary malignancies. So we really need to be aware of the complications of treatment and balance the risks against potential gains when we're thinking about aggressive therapies. So what is the definitive therapy in children? Children should have a total or near total thyroidectomy and central neck dissection at the time of initial surgery in all children with nodal metastases identified in the central or lateral neck during preoperative evaluation. And for those with anything other than low-risk disease, consideration for I-131 radiotherapy. So in an attempt to prospectively identify patients in whom I-131 therapy is indicated and limit potential overtreatment, 3 risk stratification groups were identified by the ATA Task Force on Pediatrics. And these risk stratification groups were based on the use of the TNM classification system. And you should remember that the risk groups does not define the risk of disease mortality, but rather identifies patients at risk for persistent cervical disease and determines who should undergo postoperative staging for distant metastases. So here are the risk groups. The ATA pediatric low-risk group, where disease is confined to the gland with either no nodes or incidental N1A micrometastases. These patients are at the lowest risk for distant metastases. The intermediate group, patients with more extensive metastases, who are at low risk for distant disease, but at increased risk for incomplete resection or persistent cervical disease. And finally, the high-risk group, those with regionally extensive or locally invasive disease at the highest risk for incomplete resection, persistent disease, and distant metastases. So this table, again, in the article published in 2015, defines the groups, defines what their post-operative staging should be, suggests TSH goals, and then surveillance in those who have no evidence of disease post-initial treatment. So what's different about that? Well, previously, all kids who had differentiated thyroid cancer underwent post-surgical staging with a whole-body I-131 or preferably I-123 scan. Now, the guidelines suggest that that scan could be admitted in the pediatric low-risk group who are initially assessed and followed with ultrasound and serial TSH-suppressed thyroglobulin levels, and that radioiodine may be withheld. On the other hand, the pediatric intermediate or high-risk groups are staged with a TSH-stimulated thyroglobulin level and a whole-body I-123 scan, and the decision to administer I-131 radiotherapy is based on these results. So the adults are well aware of the goals of I-131 therapy. But you should know that postoperative, as we heard, radioiodine therapy remains controversial. So numerous authors have reported improved survival and decreased progression and lower recurrence rates in those with advanced disease who received postoperative radioiodine. And there's general agreement that I-131 should be used to treat residual disease not amenable to surgical resection and iodine-avid metastatic disease. However, postoperative radioiodine therapy is clearly not of benefit of those with low-risk thyroid cancer after a complete surgical resection, based on the following evidence. Less than 1% of adults with low-risk disease who have undetectable TSH-stimulated thyroglobulin levels and a normal neck ultrasound have a clinical recurrence over a 10 to 15-year period. And further, while the use of I-131 therapy in low-risk patients increased from about 3% to almost 40% in the last 40 years, the overall survival rate in these patients remained constant, but they had an increasing incidence of secondary cancers in those with low-risk disease treated with I-131. So here's the algorithm suggested for identifying appropriate patients from the ATA intermediate and high-risk groups for those who should receive I-131 therapy. So they get their diagnostic I-123 whole body scan and a TSH-stimulated thyroglobulin. If they have no or minimal disease and their stimulated thyroglobulin level is less than 2, they don't get I-131. If it's in the intermediate range, they can either be observed or treated, and if it's greater than 10, they're treated. Those that have distant metastases go on to treatment. Those who have cervical disease outside of the thyroid bed, with or without distant metastases, are imaged further to identify possible resectable disease. And if there is amenable disease, then they go on to surgery. Otherwise, they're treated with I-131. Finally, there are no standard doses for I-131 treatment in kids. There are several approaches to dosing. You can use empirical dosing, where we administered fixed I-131 activities that may or may not be based on patient weight, or we can use dosimetry, using whole body and blood iodine clearance measures in addition to tumor surveys to provide estimates of maximum tolerated doses to the critical organs. The guidelines do not recommend for or against either approach, but really recommend that all I-131 treatment activities in children be calculated by experts with experience in treating and dosing children with differentiated thyroid cancer. At our institution, I typically use empiric dosing for initial I-131 treatment and reserve dosimetry for a select group of patients. All of us are either young or have had prior chemotherapy or radiotherapy or extensive distant or pulmonary metastases. Remember that there is a dose-related sensitivity in disease detection, so that post-therapy scans are really mandatory and may detect additional lesions in up to 46%, as in this 11-year-old who initial staging study, maybe on the left, doesn't really show any uptake in the lungs, whereas post-I-131 therapy, you can see extensive pulmonary uptake and metastases confirmed on non-contrast CT. I'm not going to go into the guideline recommendations for surveillance or long-term follow-up, but the main difference is there's not really a role for serial I-123 whole body imaging, especially for those who were not previously treated with I-131. So in conclusion, remember that children are not small adults and that there are differences in their physiology, that there's a lower incidence of thyroid nodules in kids, but a higher risk of malignancy when a nodule is identified, that children have different clinical presentations and long-term outcomes in those with differentiated thyroid cancer compared to adults, and also that there are different guidelines for evaluation of thyroid nodules compared to adults. And finally, despite the aggressive nature of pediatric differentiated thyroid cancer compared with adult counterparts, overall survival, even in those with distant metastases, is nearly 100%. But late recurrences do occur even decades after treatment. That there is an increase in all-cause mortality for survivors of childhood differentiated thyroid cancer, predominantly due to the development of secondary malignancies in those treated with I-131. So lifelong surveillance in these patients is needed, and the American Thyroid Association pediatric guidelines provide a valuable resource. Thank you so much for your attention. Here's some selected references.
Okay, thank you, Marguerite. Next up, we've got Dr. Gabrielle Chehik, who's a dual-trained nuclear medicine physician and oncologist from Flinders Medical Centre and Queen Elizabeth Hospital in Adelaide, and she'll be talking to us today about the Australian model of thyroid cancer management.
Thank you, David, for the intro. And hi, everybody. It's actually a huge honour to be able to speak today at a World Forum. I've got a slightly skewed interpretation of the talk I'm meant to give, so I do overlap a little bit, so apologies for that. So this is going to be very much an oncologist viewpoint, and I will go from global to local and see how we go. So I'm going to start with looking at the global incidence of mortality. And when we look at non-communicable disease, we can see that the incidence of cancer amongst cardiovascular disease, chronic respiratory disease and diabetes is increasing. And the numbers are increasing at quite a staggering rate. The Cancer Research UK's data is often touted, and the figures are really, as I say, quite staggering. So in 2012, some 14 million new cases of malignancy were diagnosed, resulting in about 8 million deaths. And many of these, as we know, are linked to lifestyle factors. The big four from 1975 remain the big four: lung, breast, colorectal cancer and prostate cancer. And we've already had many forums in this meeting, and there will be more to follow that will particularly look at prostate cancer. But what is important is to look at the number of 32 million. That represents a prevalence. That represents that over a 5-year period, we're doing well and these patients are surviving. And they're surviving, and you'll hear me use this term frequently, they're living with a chronic disease. However, there's no slowing down, and by 2030 it's estimated there'll be 23 million people per annum diagnosed with cancer. I spent a lot of time in the area of quality of life, and we can see that this will equate to a huge number of healthy years of life lost. This precipitated many global action plans, and the World Health Organization is just one of them. And what's really important is, apart from the multiple targets across the board, one of them is to look at how a reduction in premature deaths of young people aged 30 to 70 from the big four non-communicable diseases. So in the area of cancer in particular, prevention links into vaccination as well as screening. You'll see a lot of us refer to the SEERS database, and it's a very, very useful guide. So it's a United States-based study looking at surveillance epidemiology. The World Federation was last held in Australia in 1994, and it was held in Sydney. And at that time, the incidence in America was about 6 per 100,000. Progressively, as we've seen, there's been a steady rise in the incidence, so that from 2009, when SEERS was repeated, and again in 2014, we can see that the rate is continuing. The slope of the curve is slowing, but it hasn't reached a plateau. As we know, it still equates to excellent overall survival. And it's a similar story here in Australia. So that 1.8% of all cancers are thyroid cancers. They might be the most common endocrine malignancy, but in the scale of things, they're still relatively small in numbers. But us as females will probably have a 1 in 93 chance, or 3.1% of us females. So I think if there's 100 people in the room, I don't know how many females are in here, but possibly one of us, if we're not lucky, might get it. We know that there are multiple factors associated with this, not the least of which is we're living longer. Environmental and lifestyle factors. And I suppose aside from ionising radiation, which is probably about the only risk factor that we know convincingly, or as a consequence of previous treatment, we're not entirely sure. And there's a very significant increases in incidental thyroid nodules, which I'll talk about, as well as rising medical radiation. So if we look at these incidences, we look at the incidence of mortality of the Australian curves, you can see that, as I said, we have not reached a plateau. But again, convincingly, the data is good to show that mortality rates remain low. Sorry, and I'll just again highlight what Jeremy has alluded to as well, that we can see that there are very different very different scenarios depending on the age group. Now, this slide is a really important slide, and if you were at the plenary session this morning, and the president of IAEA and as well as Professor Payers talked about just the very significant increase in the global market of diagnostic imaging. And I think this is really, really important, because as the accessibility has increased, although CT and ultrasound predominantly are the major imaging modalities, they are becoming increasingly used, so that all of us are being exposed to more scans. And guess what happens when you have a scan? I might have a scan because I hurt my back, but they found something in my adrenal gland. I might have something because I hit my head, and they might find something in my pituitary gland. So this very good review article that was published in the American Journal of Radiology highlights all the organs, all the incidentalomas, and we can see that we can characterise them according to their clinical importance. And thyroid incidentalomas maintain a moderate importance. Taking that further, different imaging modalities have a different detection rate of incidentalomas. It can be quite high. So ultrasound studies of the neck can be performed for other reasons, say carotid ultrasound, etc. Up to 67% of these studies may show incidental lesions. 25% of contrast-enhanced CT scans. And I suppose the most telling are the incidental lesions found on FDG PET. So FDG PET performed for other indications. If the uptake is diffuse and not associated with an ultrasound abnormality, then it's probably not a problem. But if it is focal and there is a nodule, it's up to a 35% chance that this is malignant, particularly if there's an associated high SUV greater than 6.8%. So when you put all that together, what we effectively are doing, whether we intend to or not, is we are screening our populations. And because of that, we are finding a very significant number of cases that will probably never have been an issue. We know from autopsy studies that a very large number of people have thyroid, not just thyroid nodules, there's a lot of us that have thyroid nodules, but autopsy studies show that a large number of people had thyroid cancer, that indolent probably was never going to be a problem. But how do we sift out the benefit of a screening program and detecting what we think needs to be managed versus sitting on our hands and de-intensifying? It's becoming an increasing problem across all malignancies. We have to really think about how we're going to deal with that. Now, we always have known that screening for a good outcome tumour is not a good idea. And very mindful of how we approach screening. But some very important data came out of the Korean studies. So when the healthcare system in South Korea, with a population of 51 million people, underwent reform, patients were invited to also have a health check that included thyroid ultrasound. And what we saw was a staggering change in the incidence, 7-fold increase from 6.3 per 100,000 to 47.5 per 100,000. And during that time, thyroid cancer became the most commonly diagnosed cancer in women in 2004, so very soon after, and then men and women by 2009. I don't know if it's because more women chose to have their neck scanned, or whether because women have smaller necks, but 85% of their cohort were women, quite young. And as we know and keep saying, the predominant differentiated thyroid cancer subtype was papillary thyroid cancer, with the size steadily decreasing. So that these screen detected, effectively you're screening these patients, over 50% of them were our small papillary thyroid cancers. And also the distant stage was reducing. So I can add to the point that with these figures came a very, very significant increase in the healthcare budget that was attributed to this across all, from diagnosis to biopsy to surgery to complications. And so in 2015, the screening program stopped. So if I take all of that, let's remember we're always here for our patient, and we want to look at a patient's journey. And we'll be involved in the setting of thyroid cancer. This is my generic slide because, as you know, I treat a range of cancers. But if we look at a patient from the time of detection all the way through, people in the room, we might be nuclear med physicians or radiologists or technologists, we know that we have a very important role. And whether it's the nervous patient who comes in for a biopsy of their nodule, through to the time of diagnosis and treatment. Particular interest as well in the area of follow-up care and survivorship. Now, many of us will be part of either virtual MDTs or some of us in other forms of MDTs, which is an important part of our life. That was just a bit of a breather slide. I'm glad some of you appreciated it. So what is the role of a multidisciplinary team, and who should be part of that? Well, really anyone and everyone representing a whole range of different disciplines. And we come together with a range of terms of references and guidelines. Within Australia, there's a particularly good model of care that comes out of Western Australia. But in essence, you'd be happy and be most grateful if you have a dedicated pathologist, imaging specialists, and obviously the clinicians that are responsible for the referring of those patients. I think the battery is running low just for the organisers here. Okay, hang on. No. Sorry. It's not, no. Not behaving. I am, that's what I'm using. The mouse is what I've been using. I'll try this again. It's better. The ATA guidelines so the American Thyroid Association guidelines we keep referring to, and maybe people in the room use a range. The ATA are not the be-all and end-all. It's certainly what I default to, because I think the most recent 2015 combination shows a very contemporary guideline. They've looked at a range of different areas, everything from pre to post-operative management, and particularly like the direction for future research, which I'll come back to in a minute. No, sorry. That's because... My apologies. Okay, so if we single out the different specialists and we look at the radiologists, they particularly have a role to play, particularly in the pre-operative setting where we might have nodules that need to be evaluated. Totally agree that all nodules should be biopsied under ultrasound guidance. I think gone are the days of blind biopsy. And in the interest of time, I'll be very mindful about spending too much time on TIRADS, which is really important. So whether you're looking at breast with BIRADS or prostate with PRADS, the thyroid classification of nodules is very important. And it gives us a segue into trying to work out what lesions need to be biopsied and those that don't. So assuming that the patient has either had a biopsy with cytology or an operative specimen, then becomes a very important task of the pathologist. And Jeremy has already touched on the reclassification of a very significant subgroup of the papillary, of the follicular thyroid cancers, which I won't go over. I'm glad he's done that. It'll save me a few minutes. But the concept of NIFTP, which removes the word cancer, will all of a sudden hopefully reduce at least a small burden of diagnostic concern for some of these patients. Another important guideline to me, so basically what I've done is gone through the ATA guidelines and picked out the ones that I thought might be most worthy of conversation. Active surveillance is a very, very important concept, but one that is nowhere near mature enough, I think, for distribution. Basically what we're saying is we know that we are dealing not just with an excellent prognosis disease, many of which are lesions that would never have been detected had we not had incidental scanning for something else. And this is going to continue as more of us have scanning for other reasons. So we have to find a way to take a large number of these lesions out of the equation. We have to stop calling them cancer. We have to stop worrying about following them, because if we don't, we're going to find that not just the financial blowout, but the emotional cost will be huge. So what do we know? A couple of Japanese studies, which are good, but nowhere near ready to be translated across the globe, were just observational studies. And they showed that with cautious observation of lesions, you don't need to do too much. And progressive disease was defined as a change in 3 millimetres. And you can see that at 5 and 10-year time point, only a very small percentage of these lesions changed. Even if you did allow them to stay there, only a very small number of people had lymph node metastases. And quite interestingly, it was the younger ones that were more likely to progress. A further maturation of this study has been published more recently. But I find that although there's a recommendation that this is a reasonable approach, I don't know about you, but I'm yet to find a patient who's been told that they have cancer based on diagnosis that is happy to just sit on that. So our challenge is to work out how we're going to change the wording so that a patient's not sitting there and living with the diagnosis going, that's all right, I'll see you in 6 months. The anxiety that builds up in these patients is very significant. We keep hearing that the original targeted therapy was radioiodine, and we know that. And after 75 years, I really don't have much to tell you in the nuclear med space, apart from the fact that there are those that use empiric doses, there are those that scan and use dosimetry, and that's for other sessions, and I really didn't want to talk about that too much. I knew that Jeremy would be, and the previous speakers would be talking about PET. This is really just a reminder. It's a glimpse of tomorrow's case, but it's just a reminder to say that there are several things with radioiodine therapy. In our setting, we try very hard to have quite a close follow-on from time of surgery to review at our multidisciplinary meeting to referral and treatment. And although 6 months has always been touted as try and get your radioiodine within 6 months, we try and do it within 6 to 8 weeks, obviously allowing for those small numbers of patients who have had iodinated contrast with their baseline staging. And really, although they say 6 to 8 weeks is adequate, I like to leave 3 months. So this was really just to highlight what we've already seen, that it is not an infrequent occurrence to see FDG avid lesions that would otherwise be classified as iodine refractory, and SUV will become something that we will need to evaluate further in time. So we've treated our patient, they're happy. The stimulated thyroglobulin with the best possible bioassay is undetectable, and there's nothing in the neck. What are we going to do with these patients? Well, more and more, as Meg just saw, I've pointed out, more and more we want to see if we can categorise these patients, and more we want to see if we can evaluate them as excellent responders, biochemical responders that are complete or incomplete, and structural responders that are complete or incomplete. Because what that will hopefully allow us to do is elaborate on the other area that I have a great interest in that is our post-surgical or delayed risk stratification. So not just to have one bite at the cherry, not just to present these patients at an initial MDT and say, there you go, there's your plan for the rest of your life, have a good life. We need to reevaluate, we need to revisit this, and sometimes we might need to revisit it more than once so that we don't have people on lifelong surveillance. And the way that this worked is I think, very good. This reviewed on the top half versus the bottom half, the ATA versus the American versus European Thyroid Association, and grouped them as to low or high risk. At the time of re-evaluation, those were in remission. There's no significant change there. But if you could section out those that you thought were high risk, but actually were downgraded to low risk, you can see that the piece of the pie on the right means that we've got very few patients that are having unnecessary, or not very few, you've still got a significant number because these numbers are big, but we're reducing it. So when we look at future treatments and future directions, there's an enormous amount of work on molecular markers, and targeted therapy is really important, but not without its toxicities. Active surveillance is something that I think is going to become very important if we can get it right. And there's no doubt that by the change in terminology, if I was told that I have a nodule in my neck, it would be very different than I have cancer in my neck. And I know that there's an emotional thing that we have to work with that. And the other area is survivorship. Now, when we don't understand thyroid cancer, it's very hard for our patients to understand thyroid cancer. So what's really important is that we reevaluate the guidelines, and when there are updates of these guidelines, that we become familiar with them, and that is taken back to our multidisciplinary teams. And there are very good validated tools. The European Association of EORTC modules are well validated, and there's a thyroid module, and there's also one for the MD Anderson. But just a small aside, how many patients talk to you about their thyroid scar? Instinctively, they won't unless you ask them. And it's incredible how distressful this is to many people. Maybe the men can hide it with the beard, but women are much more aware of it because it's what everyone sees and it's what everyone comments on. So even something just as simple as the formation of the scar. Is it flat? Is it keloid? Is it sore? Is it sensitive? Are you getting neuropathic pain? It's a reason why it's all well and good to say, let's just go ahead and do a thyroidectomy and you'll be right. But what if they don't need that thyroidectomy? And just in finishing, just to point out that there's nothing more powerful than data collection. Cumulative data, cumulative trials to give us more power to look at what we don't need to do as opposed to what we do need to do. Mike Tuttle summarised it brilliantly. He said, and I wish I wanted to find his slide. He said many years ago it was all about nuking everything we could find, and now it's all about de-intensifying as much as possible. So in summary, the points I've tried to highlight are these. There's been a marked increase in the detection of differentiated thyroid carcinomas, as we've seen, and it's not going to slow down. Prognosis remains excellent, especially in the small, indolent, early-stage tumours. Contemporary guidelines change frequently with increasing high-level evidence, and as such, recommendations must change accordingly, and we shouldn't have just one MDM for some of these patients. Measures are in place to reclassify a significant portion of these smaller lesions to negate the effect of overdiagnosis, and it's hoped that we can relieve not just the psychological burden, but also the huge financial cost associated just with this single disease. We need to continue to address quality of life and survivorship issues, and we need to continue to collaborate. Thank you.
Thank you very much, Gabby. Gabby's from Adelaide and she's the convener of next year's Australian Nuclear Medicine Conference. So I'm sure she's going to put a great program together for next year, and thank you for your presentation now. And our final speaker, it's a pleasure to introduce Professor Henry Baum, who's the current president of the Asian Oceania Federation of Nuclear Medicine and Biology and Professor of Nuclear Medicine from Korea. Gabby may have stolen some of your data that you're going to present, but welcome and thank you for your presentation.
Thank you very much for kind introduction, and good afternoon. So my topic is Asian model. So what is Asian model? Actually, there are so many countries different. Some countries do not have nuclear medicine service at all, and some countries have different stories. So okay. So as previous speaker told, so Korea seems to be a kind of a test bed for nuclear. So North Korean nuclear bomb. South Korea is nuclear medicine, radiation therapy. Yes, it is true. Thyroid cancer is, explosively grew last decades, and almost all of them are papillary thyroid cancer. So it was by epidemiologists show this graph and emphasized it is because of screening. Because if you see here, the detection rates among Korean counties, that if there is more screening, so more thyroid cancer. They showed this graph, and after they showed this graph, everybody recognized, okay, screening is the main criminal to make this job, these findings. So after this, Korean government strongly discouraged insurance coverage for, actually the cancer screening itself is not covered by insurance. So there are so many ultrasounds. Korea is the #1 country producing ultrasound in the world. So every doctor says ultrasound. It's very easy to put probe in the neck and find out something there. But anyway, so Korean Ministry of Health strongly discouraged the screening of thyroid cancer. And even they detect thyroid cancer, in small thyroid cancers, they do not cover some advantage in insurance. Actually, 65% of thyroid cancer detected got surgery in Korea is less than 1 centimeter. 1 centimeter. So we detect very much. After the policy, thyroid cancer incidence go down like this again. But these days it's a plateau. So there is a question. It is really because of 100% because of screening. The incidence of thyroid cancer, still it is #1 cancer in Korea. So we don't know. After 10 years we may know. But the BRAF mutation rate is more than double of the other countries in Korea. So it's maybe something we have. We don't know. And recently, thyroid surgeons and many endocrinologists, so especially thyroid surgeons, eager to make some evidence of early detection and early surgery makes some difference in survival. In epidemiology, they say there is no big change of mortality from thyroid cancer. But if we look in depth, the mortality of small thyroid cancer resected and larger thyroid cancer resected are a little different. So it's a kind of, so that's why I say it's a South Korea's test bed. You may know, we can say after 10 years maybe. But it is a big trend, very conservative to thyroid cancer treatment. When ATA says that if it is less than 1 cm, so don't do surgery. But many Korean surgeons, so they say, oh, let's make it 0.5. So they think from 0.5 to 1 cm, they are really different from less than 0.5. They are collecting, evaluating actively these days. So there may be something, new findings coming soon, I think. And the radioiodine therapy is very conservatively recommended to those growth extension or metastasis or some huge ones. So in Korea, these days it's very difficult to see more than 4 cm mass there. So the radioiodine therapy is dropped significantly. It's less than half of previously we did. Okay, but there are many individual variations and individual factors which we consider to do radioiodine therapy or not. So 2 years ago, Asia Oceania Federation initiated a research network. So we say it's our Asia Oceania Research Initiative Network. So there are separate groups. Professor San Luis in here from Philippines and myself and other leaders founded thyroid group. And we, at that time, so there was a big challenge from American Thyroid Association guideline. So even European Association of Nuclear Medicine denied to accept ATA guidelines because they thought it is too much endocrinologist oriented and neglected the importance of nuclear medicine. So we cannot accept that. So they did not agree to agree for the ATA guidelines. So similar emotional thinking is prevalent in Asian group too. So we thought we need some kind of new discussions and debates for that. So we wanted to make some kind of our viewpoints and make something. So we did a survey for last 2 years. How do you treat thyroid cancer patients using radioiodine? So we have a good network throughout the Asian countries. So I send emails and sometimes phone calls several times. I collected data from 20 countries. And this result is published this month in Nuclear Medicine Communications. So I'd like to, I'm happy to share these findings with you. So most respondents have isolation therapy rooms. So five of them don't. So those centers treat them thyroid cancer only outpatient basis with low dose. And so if they have some metastasized patients, high risk group, then they refer. So it was good that many centers has isolation rooms. Actually, it's 100% of respondents are all nuclear medicine physicians, so that's why I think. So again, so in this group, nuclear medicine physicians are involved in the decision-making of radioiodine therapy, almost all, either alone or with endocrinology or with surgery. Only one center answered that surgeons decide the radioiodine therapy. So it was quite interesting from radiation safety point of view. The standard radiation release criteria from the isolation room, according to the IAEA recommendation, is 70 microsievert per hour at a distance of 1 meter. But so many centers have stricter, harder regulation. It's the lower criteria, release criteria. So it is not a kind of consensus, I think. Many countries have strict rules. They keep patients longer at the isolation rooms. This is most important. It's an interesting finding. So we collected data from them. So it's according to the risk group. And in high-risk groups, they usually treat with more than 100 millicuries. It's okay. So some centers use more than 150 millicuries. In intermediate group, they use from 50 to 150. But in low-risk group, so there are so many, so no treatment at all. It is an ATA guideline, actually. But they treat with 30 millicuries or even 50, even 100 millicuries. So it was, we got this result from the first survey. So it was very interesting why they use higher dose in low risk group. It is not recommended by ATA guidelines. So we did the second and third surveys, why you do that. So this is the result. So in 75% of respondents, they say if the serum thyroglobulin level is high, so we don't know how high is high. We did not ask that, but it's, according to the questionnaire, if the serum thyroglobulin is high, then we treat higher dose or we treat them. This makes sense. Because pretreatment thyroglobulin is quietly associated or correlated with response rate, ablation rate. So I think it makes sense. And I already told you that in Asia, so many heterogeneous practice and economy and differences. So if there is inadequate information on lymph node involvement by imaging or pathology, or if there is a limitation in pathology reporting, then they give radioiodine to make sure. So it is kind of in more than 60% of respondents told that. And so a little less, if patient compliance is poor, they live very long distance and they cannot come again and again, then they give radioiodine to make sure. And if they cannot follow up the patient, then they prefer to give radiodine. And if the health insurance is not covered all the treatment, then if the patient come again and again, and then if the resurgery, then it makes a big difference of financial burden for the patient. So they'd rather give radiodine. So those are clinical social factors we found from the survey. So I think it's makes sense in some sense, but otherwise we may discuss again and again to find a better solution for our patients. So that is a challenge in our research group. So we asked, what kind of guideline do you use? Do you adopt? So ATA guideline, only 37% adopted them. Then what do you use? A TNM classification, or both ATA and TNM, or just fixed dose without any guideline? Or we have our own guideline and others. So it is evident that many nuclear medicine physicians in this region, still we don't have a kind of consensus yet. So we need some kind of training, education, or communications, I think. Follow-up protocols. Thyroglobulin is everywhere, but imagings are different. Somebody use ultrasound, somebody use both ultrasound and whole body scan, and somebody use only whole body scan. We usually recommend to add imaging study to thyroglobulin these days. So we recommend like that. So what do we recommend for basic requirements of thyroid therapy, radiodine therapy? We recommend to consider post-operative status, disease status for decision. So please see all the pathology reports and the thyroglobulins and so on. And please group the patient into low risk, intermediate, high risk group. And please use thyroglobulin, antithyroglobulin antibody, or TSH before radiodine therapy. And so dose selection, please see the risk group. And so those we recommend, actually, so we are on the same line of ATA guideline. Please don't do radiodine therapy for low risk, or even if you want to give just small dose, so less than 30 millicuries or 30 millicuries. For the intermediate risk group, according to the patient condition or various factors, you can give some 30 to 50, but less than 100. High risk group, you can, if you can do dosimetry and patient-based, you can give a higher dose. So these are kind of recommendations and the way we go. And so if you have gamma camera, you may have. So after therapy, please check whole body scan, no exception. Please check whole body scan after therapy. There is a kind of recommendation. And during follow-up, thyroglobulin is important. And the ultrasound and other imaging modality, if you can do, please do. So, and then we released these 6 recommendations and asked them, how much do you accept? So number 1, 2, 3, 4, 5, 6, or accept more than 90%. So it's good. It's good. So they agreed for our these recommendations. Is now the challenge for us is to spread this information more and more to as many countries as possible. So in summary, the majority of respondents adhered to the recommendations suggested by our research group. and the majority of enrolled institutes consider several clinical social factors beyond guideline-based risk stratification to select those, especially in low-risk group. It appears that patients' clinical and socioeconomic conditions and healthcare providers' work facilities, as well as clinical expertise, should also be considered for rather than therapy. And the last summary is, although this is an Asian survey, our results, issues, and clinical social factors may be used to elucidate the heterogeneity of therapeutic practices among the thyroid physicians of other regions as well. So future studies are needed to address and promote close harmonization of therapy practice in Asian countries. So using this opportunity, I want to express my gratitude for all the participants, especially the leading group of this survey. Thank you very much.
Okay, thanks, Professor Bowman, for that excellent presentation.